A very good morning to the honorable panels and my fellow colleagues. I'm Dr. Chow from the Malaysia. Today, I would like to bring to you my study regarding neuropsychiatric manifestations in COVID-19 infections in patients and its long-term outcome in Malaysia. So let me have a brief introduction. So up to today, WHO has reported 768 million community cases and 6.9 million community deaths for COVID-19. All this was attributed to our SARS-CoV-2 virus, and it was changing over the times. Because of it changes over time, it will affect the virus properties, transmission rate, performance of the vaccines, and also severity of the disease, as well as a detection rate by our diagnostic tools and the effectiveness of our treatment. So our treatment has been keep updating by according to all the variants. The latest variant concern was the Omicron that we have been known for so far. So besides affect the respiratory system, the COVID-19 also affect other multi-systemic. So today, my study will be focused on the central nervous system. The most prevalent central nervous system symptoms include hyposmia or anosmia, ageusia, headache, and myalgia. The central nervous system sequelae or persistent symptoms, which we name it as a long COVID symptoms, are make up of 20.8% attribute to the central nervous system symptoms. And the most prevalence for the long-term COVID-19 symptom is a persistent anosmia and also dysgeusia, followed by headache. So patients may also experience psychological effects for the COVID-19, such as increasing stress, anxiety, or depressions. And studies also show that those suffering COVID-19 has risk for suffering neurodegenerative disease, such as Alzheimer's disease. So my objective is to determine the prevalence of short-term and long-term neuropsychiatric symptoms in COVID-19 infections, to study the associations between the social demographic background in patients who develop short-term and long-term neuropsychiatric symptoms, and also to determine the association between the severity of the COVID-19 infections in patients who develop short and long-term neuropsychiatric symptoms. So this is a methodology of my study. This is a prospective observation studies conducted in the hospital Malaysia in the state of Johor. Means this is a gazetted hospital for treating of the COVID-19 in the state. So all the patients who in this state due to COVID-19 had to send over to this hospital. So my inclusion criteria will be the COVID-19 has to be confirmed by the PCR, and also the patient has to be more than 18 years old and admitted to the hospital. Exclusion criteria is negative for PCR or not require hospitalizations, before the follow-up, pass away, decline or unable to participate, or has a pre-existing psychiatric disorder which can impede in the participation in this study. So 300 patients were randomly selected to this, and we will further categorize into mild COVID-19 and severe COVID-19. The severity and categorization was according to our Malaysia CPG guidelines. So the mild COVID-19 has been further categorized into stage 1, 2, and 3. Stage 1 is asymptomatic. Stage 2 is symptomatic but no pneumonia changes in the X-ray. Stage 3 is symptomatic and pneumonia changes in the chest X-ray. However, for the severe, they are all require oxygenations. Stage 4 is symptomatic and chest X-ray changes and require oxygenation. Stage 5, which is a critically ill patient with multi-organ failure and require higher oxygenation, such as non-invasive ventilations or even intubations. So the patient will be selected and assessed in our wards, and then we will follow them up to 6 months to assess any persistent long-term neuropsychiatric symptoms, or by using a video call or phone call. Why we choosing a video call or phone call? Because at that time, the COVID-19 is a pandemic, and our isolation policy was encourage us not to go out if you have not necessary. So we try doing this to avoid, to reduce the exposure risk of the patients. So all the assessment tool, we are using a quite formal standards, such as by assessing cognitive function, we're using the 6-item screamer. By assessing depression, we're using a patient health question 9. Anxiety, we're using GET7, and confusion scale, you're using a CAMS-S. All this has been gained the permission for the original order. So this is my bedside characteristic of my study cohort. So it's a quite equal gender. Male consists of 40%, female 49%. The average age for my patient was 47. Because Malaysia is multiracial, so but mainly my Malay will be comprised of up to 82% in this study. Risk factor, most of my patients has 69% have risk factor. Those risk factors are the premorbid such as hypertension, diabetes, chronic kidney disease, or ischemic heart disease. And you can see from my study, most 50% of my cohorts was comprised of stage 2 disease. So these other clinical requirements. Most of my patients doesn't require oxygenation, 70%. Steroid use, up 30% requires steroid use, and 2% only admit to ICU. And most of my patients, 80% has been completed with COVID-19. Completed vaccine means they have to receive at least 2 vaccinations, 14 days at least before to get the COVID-19 infection. So this is my prevalence of short-term and long-term neuropsychiatric symptoms. From here, we can see 78% of the patients suffering from short-term neuropsychiatric symptoms. But after 6 months, most of them greatly improved and only left to 22% having the persistent symptoms. So from here, we can see from the short-term one, the most prevalent symptoms are ageusia, which is 38%, anosmia, 45%, myalgia, 36%, followed by the headache, 36%. To compare to the long-term psychiatric symptoms, the most prevalent symptom is a myalgia and headache. Both of them are very statistically significant. And we have to see that I have one patient who has a seizure, and after 6 months, he still has some seizure. So this is maybe worth to see. And paresthesia also quite a number, 6% of them, and 4% of them persist to have the paresthesia symptoms. So next is after we see the neurological, we look at the psychological aspect. So majority of the patients, 73% having mild depressive symptoms, and also 76% having a mild anxiety symptom as well. And both of these have persist up to long-term symptoms. You can see after 6 months, 21% still have a mild depressive and 21% still having anxiety. But they all only have a mild symptom only. So worth to see here, the sleep disturbance is also troublesome to our patient. 80% having the sleep disturbance, even 6% persist after 6 months, and loss of concentration as well, and also memory disturbance. Memory disturbance, you can see 4%, almost the same, has some brain faults and memory mild cognitive impairment, even up to 6 months. This may let us think about maybe this will correlate to the neurodegenerative disease, such as Alzheimer. Patients with the suffering for COVID may have a higher risk to get Alzheimer disease in the long run. So this is a table showing any association or predictor of the short-term neuropsychiatric symptoms. So from here, you can see the statistically significant is stage 2 and stage 3. They are higher risk to get short-term neuropsychiatric symptoms. Other than that, oxygen or ICU or COVID-19 vaccination stations doesn't show any correlations to the short-term neuropsychiatric symptoms. Okay. So this is an association and predictor for long-term neuropsychiatric symptoms. From here, the only statistically significant is vaccination. Those complete COVID-19 vaccine tend to have a higher risk to get the neuropsychiatric symptom in the long-term outcomes. Later, I will explain why we get the result like this. So explain my result. So the number of patients with a short-term neuropsychiatric symptom was higher, which is 78% in my study, while those having a long-term symptom was almost similar to other studies. Why my study getting a higher short-term symptoms? This is because at that time, the publication has a very good education regarding COVID-19 symptoms, as well as we have a lot of educations online, Facebook. We talk about COVID-19 not only affect the respiratory, also affect the other things, multi-systemic. So they tend to think, oh, this is a COVID-19 symptom, so they immediately come to hospital. So this heightened awareness and anxiety among the publication has bring us to get more short-term neuropsychiatric symptoms reported by the patients. And the most prominent short-term neuropsychiatric symptoms is anosmia, agusia, and these two are almost similar to other studies as well. Mild depression and anxiety was common during acute infections and also long-term follow-up. This may due to the influence by the health worries and also society stigma, isolation policy, financial strain, and also health concerns. So all these multifactorial can cause a patient to have more anxiety and depressions because COVID-19 not only affect our health and also economy, the worldwide economic recession made a lot of patients lost their job. This anxiety, depression can contribute to the concentration loss and also sleep issues such as insomnia. So our study also revealed that short-term neuropsychiatric symptoms mostly prevalence in the mild COVID-19 patients, such as stage 2 and stage 3, as we showed before. This is because those patients in the mild disease tends to have a symptom such as anosmia and agusia. All this is due to we have a nasal defense against all this virus. So they tend to have a report mild symptom as this, so they categorize into stage 2. Those severe cases, such as require oxygen, they usually has a preoccupied by the lung inflammations, and they may too ill, and they may overlook those mild symptoms and underreport the symptom to us. Interestingly, my study showed that completing COVID-19 vaccine show to have a high risk to get a long-term neuropsychiatric symptoms. This is totally different from other study, maybe because my study having a longer duration of follow-up up to 6 months, as a previous study follow up to 3 months. And this is a different variants of the virus at the time when we're carry out the study, and different social demography in the Asians, and also additional stress-related factor in our Asian, which is middle-income countries. So, and other than that, in Asian, I think they tend to have perceptions regarding the vaccine is not good to them. They tend to have a fears regarding the vaccine. So anything contributing to the symptom, they may all blame to the vaccine. So this might tend to have a more reported like anxiety, depression, headache, all this as a long-term neuropsychiatric symptoms. So my limitation for my study is this is a small sample size, which is only 300, and mostly my patient has been vaccinated. So my non-vaccinated group is only 16% in this study. And it's impossible to confirm all the long-term neuropsychiatric symptoms was solely caused by the COVID-19. And as I have no other comparison group for it. Those suffering severe COVID-19 patients may not able to provide a clearer history and underreport the neuropsychiatric symptoms to us. Okay. So conclusion, neuropsychiatric symptoms are common among COVID-19 patients, and most of these symptoms improve after 6 months. The most prevalent short-term neuropsychiatric syndrome was anosmia, agusia, headache, and myalgia, whereas the most frequent long-term neurological symptom was a headache, myalgia, and sleep disturbance. The risk of this symptom is associated with the severity of the infections, such as stage 2 and stage 3 COVID-19 tend to have a short-term neuropsychiatric syndromes. Social demography and premorbid do not correlate with the short and long-term neuropsychiatric symptoms. Complete vaccine does not completely protect against the long-term neuropsychiatric deficits. This finding will emphasize the importance of monitoring and addressing the neuropsychiatric symptoms in COVID-19 patients. Further follow-up and monitoring for any potential neuropsychiatric symptom or neurodegenerative disease is warranted. Thank you.